Hello, everybody. My name is Stephanie Nava, and I will be managing this event on the back end. Before I introduce Dr. Scott Roberts, I just wanted to thank you all for coming out today. We will be having some Q&A towards the end of this talk. You can put your questions in the chat, and we'll be sure to address them after Dr. Roberts is finished with his presentation. And without further ado, I would like to introduce Dr. Scott Roberts. He is a professor in the School of Public Health, and he also serves as our ORCOR lead at the Michigan Alzheimer's Disease Center. And without further ado, I turn things over to you, Dr. Roberts.
Yeah, well, thanks, Stephanie, and greetings from Ann Arbor, where we're still basking in the glow of our national champion Wolverines. Usually I like to give talks in person, but today's one of those days, given the snowy roads, it's nice to be able to convene via Zoom. And so, as Stephanie mentioned, I'm part of our U of M School of Public Health and the Alzheimer's Disease Research Center. And I'll be talking today about genetic and biomarker testing for Alzheimer's disease. And this is a topic that's of great interest to me. Even though I'm not a geneticist by any means, or even a neuroscientist, I'm actually a clinical psychologist by training, and I've done a lot of research on how people respond to learning results from genetic and biomarker testing. And so I'll be talking a little bit about that research today in the course of this talk, but I want to give you kind of a broader overview of the field as well. So before I get into, I'm going to start with genetic testing, but before I get into that, I would like to kind of remind us all that when we're talking about Alzheimer's disease, genetics is certainly an important component of that, but as it is a multifactorial complex condition, there's a lot of other things that influence whether someone develops Alzheimer's disease or not. And so this slide is meant to kind of convey that. I'm not going to kind of march through each of these risk and protective factors, but just the point is there are certain things that elevate one's chances of developing Alzheimer's. You can see on the left, and many of those are things we really don't have a lot of control over. On the other hand, there are some known protective factors as well. So there are things one can do in terms of health behavior and managing one's physical health that might be useful as well. So keep that in mind because we're going to do a lot of focus on genetics and biomarkers, but I don't want to lose sight of the complexity of this condition. So let's start with talking about genetic testing. And before I talk about genetic testing for Alzheimer's disease, just want to kind of let you know it's really becoming an increasingly important part of medical care here in the US in the 21st century. And you can see here, there's a lot of different ways you can do genetic testing. The scope can be different. You can test for single genes all the way up to sequencing the entire human genome, which we can now do for just a few $100s. There's different purposes of genetic testing, and the ones in bold are the ones I'm going to talk about most today. So you can see the first two types of genetic testing I've got listed here are predictive and susceptibility testing. And the idea behind these types of testing is to test for genes that might place people at risk for a given medical condition. So they don't have symptoms right now, but they might develop it in the future. And the difference between predictive versus susceptibility is predictive means that the genetic test is pretty accurate in identifying who will go on to develop Alzheimer's disease or another condition, whereas susceptibility testing is more if you're at higher risk. It's not for sure that you're going to get the disease, but you are in this at-risk category. Of course, we can use genetic testing for diagnostic purposes as well. So for certain types of Alzheimer's and other neurological conditions like Huntington's disease, if someone is having symptoms and you're trying to figure out, well, what's the underlying cause, genetic testing can be helpful in making a diagnosis for conditions like Huntington's, where the gene change really is the root cause of the disease. And we'll talk a little bit today about pharmacogenomic testing, where you can use genetic testing to inform choice of medications. So the ones in bold are really the ones I wanted to highlight, but I also wanted to include these other types because it really is becoming so commonplace now in medical care to use genetic testing for a variety of purposes. Just to say a little bit more about genetic testing in the context of Alzheimer's disease. So this table is taken from a paper that a postdoctoral fellow, Drew Blasco, wrote with me recently. And so you can see there's some of the types of testings I just talked about. This gives you a sense of what's the purpose of these different types of testing, what's the target population, and what are the specific genes being tested. And you can see, as I'll be talking about, certain types of genetic tests are really more just for research purposes. Some of them make their way into clinical practice. And nowadays, some are even getting into the direct-to-consumer marketplace. And it's kind of controversial, but there are now some companies that offer genetic testing without having to go through a physician or other medical intermediary. So these are some of the types of testing that are relevant for Alzheimer's disease that I'll be talking about in the next several slides. And just to, again, kind of put some context here, this is a little bit of a complicated chart, but it kind of shows that there's a lot of different genes out there that might be relevant for Alzheimer's. Some of them are very rare, but highly predictive, like the APP, PS1, and PS2. Some of them, like this ApoE4 allele, are relatively common in the general population and also notable in terms of how important they are to cause Alzheimer's. And there's a whole bunch of other genes that are relatively common in the general population, but maybe play a very small role in the development of the disease. And so I think as the field moves on, right now I'll be talking mostly about testing for those specific genes at the top of this chart. But I think ultimately in the field, we'll see testing for many different kinds of genetic variances at once. And you may have heard of this type of genetic test that is really kind of a combination of many tests at once. And so there's this whole concept of the polygenic risk score that might be able to combine many pieces of genetic information to give us information about a person's risk. So let's talk a little bit more about predictive testing. So I mentioned that you saw in that previous chart, there are these rare mutations on chromosomes 1, 14, and 21, known as the amyloid precursor protein and presenilin genes, that if a mutation is present in one of those genes, it almost inevitably does cause Alzheimer's. So that's highly predictive. And really, these mutations are fortunately very rare in the general population, and they account for a very small minority of all Alzheimer's cases. But people who have these mutations often develop Alzheimer's much earlier than we see in typical cases. So there have even been people in their 30s and 40s coming down with the symptoms of Alzheimer's disease, and often their course of disease is more rapid. The symptoms progress, memory loss, and other cognitive concerns unfold more rapidly than we see in typical cases of Alzheimer's. So if you're a pop culture junkie like me, you're probably aware that there was a best-selling book turned into a movie called Still Alice. So I put that movie poster here. Julianne Moore won an Oscar for portraying a college professor in her early 50s who had one of these rare early onset forms of the disease caused by a rare mutation. And so the film depicts her adult daughters have to figure out, would they want to know their chances of developing it, because the way it works in familial Alzheimer's is that the adult children have a 50-50 chance of having the parent passed on that mutation to them. And so it raises some pretty dramatic decision-making issues when these kinds of mutations are identified in a given family. So we do have, U of M has a neurogenetics clinic, for example, and there are these specialty clinics around the country where if someone has a very notable family history that might suggest the possibility of familial Alzheimer's, where this predictive testing can be done. But typically, it's really kind of up to the person if they don't have any symptoms to try to figure out would they want to know this information or not. Because as you might imagine, some people would say, of course I would want to know because I want to plan my future. Whereas others would say, well, if there's not much I feel like I can do, this would be too psychologically devastating to learn. So a lot of people, put it off because of the fear of what that information might mean for them. And given that these decisions are very important, dramatic, might really depend on patient values and preferences, and there's no kind of one size fits all. I wanted to kind of point out the importance of genetic counseling for genetic testing contexts like this. So genetic counseling refers to a field where genetic counselors are master's level clinicians, and their training gives them expertise in both medical genetics as well as patient education and support. And so I think they are very valuable in helping patients and families think through these test decision-making issues. And so what typically happens in genetic counseling in the context of Alzheimer's is we see, someone might meet for a full pre-test education session to really think through the implications of results. So one of my colleagues says it's not like other medical tests where it's like checking a box on a form. You really need to talk through the pros and cons, what the results might mean, not just for the patient, but for family members, because there can be ripple effects for them as well. And then after pretest education, if the person does decide to learn their genetic results, we usually have post-test disclosure sessions where if it is a positive result, then ideally there would be support provided in coping with the impact of that information, recommendation for resources, etc. Now, one challenge in the field is, as I'll be talking about genetic testing in Alzheimer's and many other areas of medicine, we're seeing increased use of this, and we just don't have enough genetic counselors to go around to really be able to meet with everybody who might be considering a decision. And so that's one of the workforce challenges, is how can we train other providers beyond genetic counselors, given they're relatively small in number nationwide. So that's a little bit on predictive testing. Again, these rare mutations that almost inevitably cause Alzheimer's. Now I want to talk a little bit about a gene called ApoE, which is often used for susceptibility testing. And so ApoE, it's a plasma protein on chromosome 19. And so we all have an ApoE genotype, and there are three common ApoE alleles known as E2, E3, and E4, and we inherit one allele from each parent. And so the thing for you to know is that it's the E4 allele that is the well-established risk factor for Alzheimer's. So we've known since the early 1990s that E4 is an important Alzheimer's risk factor. But I think even though it's an important risk factor, it's also important to keep in mind that if having an E4 is neither necessary nor sufficient to cause the disease. So you could have an E4 allele and never get Alzheimer's. You could get Alzheimer's disease with not having an E4 allele. But ApoE, interestingly, it's also relevant for other health conditions beyond Alzheimer's. So E4 is also a modest risk factor for heart disease, for example. And interestingly, sometimes the genes seem to play different roles in different directions. So E2 is actually modestly protective against Alzheimer's, but it seems to elevate risk for a certain type of hyperlipidemia. So given this complexity, again, it kind of underscores the importance of genetic counseling and patient education, because this can be very confusing to kind of keep all of this in mind. And again, when we're talking about susceptibility testing, we're talking about kind of probabilities where people's, what we call numeracy, their ability to kind of weigh quantitative information comes into play. Just to give you a little bit of detail on ApoE genotypes in the general population. So I mentioned that we inherit, one ApoE allele from each parent. So you can see these are the ApoE combinations that one could have on this chart on the left here. And you can see that having an E4 allele is relatively common in the general population. So if you add up all of those pairs with an E4 in them, it's over 25% of the general population has at least one E4 allele. And if you're in this category at the bottom there of E4, E4, if you have two E4 alleles, one from each parent, then your risk is even higher for developing the disease. Now, how much higher and what are these risks? Well, you can see from this chart here that in the general population, the risk of Alzheimer's is about 10 to 15%. You can see that having one E4 allele about doubles that risk. And if you have two copies of E4, if you're what we call an E4 homozygote, then your risk might even be over 50% lifetime chance of developing the disease. So you can see why it's definitely an important risk factor, but on the other hand, it's not quite as predictive as those rare mutations I was referring to earlier with familial Alzheimer's. So there's been a lot of controversy over ApoE genotyping, like should we use it? or not in the medical system. And in general, medical experts say it's not recommended for routine use. And I think this is for a couple reasons. One is those limitations in the predictive value of the test that I just pointed out. It doesn't give you that yes or no answer, you're going to develop this condition or not. And that coupled with the general lack of effectiveness of Alzheimer's treatment and prevention options is really gives clinicians some pause about this. It would be one thing if we said, oh, you're at higher risk, let's put you on, like we do with heart disease, let's put you on a statin so we can lower your chances. We don't have that kind of option in Alzheimer's disease. There's also, concerns about the potential harms of this information. Will people misunderstand and assume they're definitely going to get the disease? Will they be psychologically distressed? Could there be stigma? So I think there's been a lot of caution in the medical community about routinely offering ApoE genotyping to people who, for example, have a family history of the disease and are interested in learning more what their chances are. But even though there's been that caution in the medical community, there's a lot of public interest out there. When you do surveys of the general population or those who have a family history of the disease, the majority of people say, yes, I would like to know what my ApoE genotype is. And folks in these kinds of surveys feel like the information might be useful in helping them plan for the future or making healthcare decisions. Or in our studies, a lot of people have just had this general sense that knowledge is power, and I would rather know this information if it's out there than not know it. I mentioned before the idea of direct-to-consumer ApoE testing. So even though we don't see it done a lot in the medical system, the companies like 23andMe that I'm sure you've heard about do offer this possibility. So back in 2017, the FDA granted approval for 23andMe to offer direct-to-consumer genetic testing for ApoE. And of course, they do a lot of other conditions as well and ancestry information. So ApoE is one component of what 23andMe and some other companies do. And it's generated some controversy, but in general, the fact that FDA gave their approval means that they have some confidence that the test is, gives an accurate read on ApoE genotype, and the website does give some educational information, though it does not provide that genetic counseling that I was talking about earlier. So I mentioned earlier that we've done a lot of studies looking at disclosing ApoE genotype and how folks react to learning this information. Fortunately, we found that people have generally done well in understanding what the results mean. They get the fact that even if they are E4 positive, doesn't mean they'll definitely develop the disease. They also, fortunately, in our studies, we have not seen significant distress reactions. Some people maybe initially respond with some concern and anxiety, but are typically, by 6 weeks or 6 months are back to their baseline levels of depression, anxiety. So we have not seen really clinically significant distress as a rule even when they learn the bad news about their higher risk. We've also done some work trying to identify ways about how can we provide quality genetic testing and education and counseling in a way that maybe is going to be more scalable, because I mentioned this workforce shortage of genetic counselors. So we've been able to show that we can achieve good results in terms of using brief sessions where maybe we don't have the full pre-test in-person education. We can do it in a briefer way. We can use things like telephone or telemedicine. So I think these streamlined approaches are important to keep in mind if we're going to try to scale this up in the future. And then interestingly, of course, people use this information in a variety of ways. And so we found that people who learn they're at elevated risk, it's prompted a range of responses, both in terms of health behaviors, what people do in reaction, and in terms of their advanced planning. So one of the health behaviors that people have responded with, and we're not quite sure if this is good news or bad news, is a lot of people add some kind of nutritional supplement or vitamins, and sometimes that might make sense. There's some potential evidence, for example, that things like vitamin C, vitamin E might be useful. But there is this kind of emerging nutraceutical market out there. You can see some of the products listed here that I do worry make claims that I'm not sure are really truly supported by the data. And so I think this is a broader issue for society is, how do we want to educate older adults about, a whole range of products that we're now seeing coming on the market, not just in terms of nutraceuticals, but other programs that are promising to, help you keep sharper for longer. So I think some of these products, these nutraceuticals aren't evaluated in the same ways that prescription medications are. And so I think that's something to keep in mind, is that maybe my tagline tends to be, if something sounds too good to be true, it probably is. And so this idea of, should people be taking, these supplements or not to enhance brain health is an interesting area. I mentioned that people made some advanced planning changes. One common change was people used ApoE results to inform long-term care insurance decisions, which makes some rational sense. But I think that raises this broader issue around genetic discrimination. So I thought it'd be important to point out that we do have federal laws on the book. So you can see this Genetic Information Non-Discrimination Act it was passed back in the Bush administration in 2008. So it is actually against the law for health insurers and employers to use genetic information against people. So it'd be illegal for an employer, for example, to not offer someone a job or deny them a promotion because of their genetic status, or charge people higher premiums. Like, health insurers are not allowed to do that. And so I think that's important for people to recognize, that there are these federal legal protections against genetic discrimination. However, this federal legislation does not apply to certain types of insurance, and long-term care is one of them. Long-term care, disability, and life insurance are not part of GINA's protections. I'm not saying that those industries are engaging in genetic discrimination, but again, in terms of informed consent for testing, I think it's important for people to be aware of what legal protections they have, and what are the limits of those legal protections. And of course, this goes beyond just Alzheimer's, but for all kinds of other conditions as well. There's been a lot of genetic testing in research studies, of course, as well. And so I mentioned, we do this at our center, where you can easily get genetic information from saliva sample or blood sample. So it's very easy to do, and so it's routinely done. Typically, genetic results are not returned to participants in research studies, but more sites, including our own, are thinking about, how do we disclose? And some of our own studies, like this REVEAL project that I've been part of for many years, that's been the explicit focus of the research study, is to give people their genetic information. And I think genetic testing has now become a part of some clinical trials looking at new treatments for Alzheimer's. So there have been, and some of you may have heard about, some major Alzheimer's prevention trials, where the idea is, we want to test whether a given medication maybe delays the onset of Alzheimer's in a population that is not symptomatic, but might be at high risk. And so some of these studies, like the ones listed here, have used different means of identifying high-risk groups. So sometimes it's genetics with ApoE, or some of those rare familial Alzheimer's mutations I mentioned earlier. Sometimes it's biomarker information, which we're going to get more into, like amyloid neuroimaging, seeing whether amyloid plaques are there in the brain. So we're seeing disclosure of genetic and biomarker information being done more commonly in the context of these drug trials, where they're trying to figure out who should be eligible to take part in the treatment study. And so some of you may have heard of some of these major trials listed here. The Alzheimer's Prevention Initiative in Colombia, South America, was a really fascinating one that I was tangentially involved with. Unfortunately, many of these trials have had the results, like you can see from this New York Times article that we saw in the Colombian trial, was that the medications have not succeeded in delaying onset significantly. So this was a fascinating study where they looked at almost 170 asymptomatic people in Colombia who had one of those rare disease-causing mutations I mentioned earlier. But unfortunately, in this study, they were testing a particular anti-amyloid therapy. They did not see differential results compared to the control arm. And so studies like this have raised some doubts about, this amyloid hypothesis. We've had some more recent successes since then, with some treatments that I'll get more into. But for the most part, these prevention trials with using genetic testing and identifying high-risk groups, we haven't seen kind of a breakthrough yet in that line of research. I think it's also important to mention um, genetic tests can be useful to think about medication decisions because we know that genetics plays a role in how people metabolize medications. And a lot of times these tests, when we think beyond Alzheimer's, they're used for a variety of purposes, but they're often used to identify people who maybe wouldn't be a good candidate for a good medication or for a certain medication. So for example, there are people with certain genotypes where it might predict that they're likely to be a poor responder to a given medication. It's not likely to be useful for them. Or maybe even worse, not only would they not respond, but maybe they would be at high risk for certain troubling side effects from the medication. So sometimes this genetic testing can help, decide, is this the right medication for you? And I think we might see more of this in the context of Alzheimer's. So I did mention that there have been a lot of failed anti-amyloid therapies, but in recent years, there have been a few successes. So we have had now two medications that you may have heard about, Aduhelm and Leqembi, that are now FDA approved for treatment of mild Alzheimer's disease. And what does this have to do with ApoE testing? Well, ApoE is relevant to risk of this side effect of these treatments known as ARIA. So ARIA stands for amyloid-related imaging abnormalities. And so these two medications that I've listed here do have the potential to cause ARIA, which can result in minor swelling in the brain or microbleeds in the brain. Fortunately, these are typically benign, but in certain cases, they can lead to mild symptoms like headache or nausea, or in very rare cases, they might even lead to need for hospitalization. So ApoE4, I mentioned earlier, if you're an E4 carrier, you're at elevated risk for Alzheimer's. In the context of people who are already diagnosed with Alzheimer's, E4 can be useful in thinking about should you go on one of these therapies because E4 carriers are at higher risk of having these side effects. So knowing you're an E4 carrier, maybe it affects your decision with your doctor whether you should even try this medication. And if you do try the medication, maybe it suggests a need for closer monitoring for these side effects. So maybe more frequent neuroimaging, for example, to see if these brain swelling or microbleeds are actually happening. And I know this is a complicated slide here, but this was from the phase 3 trial of lecanemab, one of the drugs that was approved, now called Leqembi on the market. You can see from this, if you look at just that top row, the chance of having that one type of those ARIA side effect symptoms is much greater in the groups that have the E4 carrier. And particularly if you have two copies of E4, you can see on that upper right, it's about 32.6% chance of having that side effect, whereas the placebo group had about a 1.7% all the way on the left side. So, so ApoE4 testing, the point is, can be potentially useful in informing these decisions about whether a patient should go on these new drugs for Alzheimer's that are now on the market. And in the most recent appropriate use recommendations for lecanemab, you can see that these are kind of experts in the field giving their views on what are the appropriate uses for this medication. You can see they have a very explicit recommendation for ApoE genotyping of all treatment candidates, you can see. And so that's a big deal to be thinking about. Now, I think this poses some challenges for the field as well, because again, I remember I talked about genetic testing and counseling. We don't necessarily have the workforce. Usually people prescribing these medications are neurologists or geriatricians. So I think it may mean that we need to think about how do we educate neurologists and geriatricians to have these conversations with patients so they can convey the pros and cons of learning ApoE genotype. Because again, maybe it has implications not just for the patient they're treating, but their adult children might be affected because if you find out you're an E4 ApoE homozygote, that means all adult children will have at least one E4 allele themselves, given what we know about, genetics in families. And so thinking about these ripple effects of genetic information, I think are important when we think about provider education, not just patient education. So, what should we tell those who are interested in genetic testing? Again, the field, as I mentioned earlier, is relatively conservative. So even though these guidelines are over a decade old, they're still the most recent kind of professional statement from kind of major groups like the American College of Medical Genetics, National Society of Genetic Counselors. And you can see they tend to be skeptical of the use of ApoE genotyping, and particularly in a direct-to-consumer context. I'm not quite as pessimistic. I think our research has suggested that people can understand some of these nuances and can decide for themselves whether it's useful. So I wanted to point out, though, that sometimes maybe these things like patient decision aids might be useful for people. So there is a decision aid for ApoE testing that's out there, developed by some colleagues of mine at Virginia Tech. So they have this genetestornot.org website. So this is kind of this online tool that people can use. Maybe they're interested in ordering a direct-to-consumer ApoE test, but they're not quite sure what the pros and cons are. So I think things like this that can maybe help people decide and make truly well-informed choices can be useful. So I just wanted to make this audience aware, if it's something that you're contemplating or know people who are interested in genetic testing, this might be a useful resource. So that's a lot about genetic testing. So let's shift gears a little bit for the remainder of the talk to talk about biomarker testing, which raises some of the same kinds of issues in terms of the implications of results. But I think this audience probably knows well that Alzheimer's disease kind of occurs slowly over time in terms of its manifestation of symptoms. You can see that people start with no symptoms at all, but they start in this preclinical phase to start having brain changes that might ultimately lead to Alzheimer's. Then folks progress to the mild cognitive impairment stage, and then ultimately, to the different stages of dementia due to Alzheimer's disease. Now, biomarker testing can be done, at any point along this continuum, but I think we've seen a real focus of trying to think about biomarkers done in the very early stages of the disease, or even in the preclinical stages before anybody has any symptoms. And so what we know is that biomarkers can mean a lot of things. We can mean amyloid plaques, we can mean tau tangles, we can mean for inflammation in the brain or atrophy in the brain. But it does seem like there is this predictable course of different biomarkers being relevant at different stages along the way. And so you can see on the left side of this, the amyloid plaques, we now know that they might start to develop in the brain 10, 15, maybe even 20 years before any memory symptoms or other cognitive decline is observable. So I think there's been a real push in the field to try to think about how can we use biomarkers to identify people early on, where we can maybe intervene in a variety of ways, whether it's not just medications, maybe it's thinking about, non-pharmacological approaches as well, changes in diet, exercise, et cetera. So there's a lot of different ways in which biomarkers can be useful, and they can take different forms, as you can see from this chart here. And again, the idea here would be, in an ideal world, we're testing people in this preclinical phase, and then maybe we can apply treatments or recommendations early on to give people the best chance of kind of progressing longer through the life course without notable cognitive decline. And I think on the research side of things, there's been this scheme known as ATN to think about, can we classify folks according to those three metrics? And what do I mean by that? So the A stands for, is amyloid present in the brain? So that's the A of the ATN, is do amyloid plaques, are they happening? And we typically think about using things like PET scans and neuroimaging, but you can also use lumbar punctures for cerebrospinal fluid to detect presence of amyloid. The T stands for tau. So the tau tangles that are another cardinal feature of the disease are also important to know about. And so again, neuroimaging or even blood tests now can be thought about for presence of tau. And then the N stands for neurodegeneration. Do we see any kind of, for example, brain atrophy or other changes that might be, you could pick up via an MRI, for example, or a PET scan. So the idea here is, and right now it's only being thought about more in a research context as opposed to medical care, but can we classify folks as to whether or not they're positive or negative on the A, the T, and the N? And so if we do this, you can see that we might have different ways of classifying folks. And so really kind of maybe getting more nuanced into rather thinking of Alzheimer's as one kind of homogeneous grouping of people that maybe it would allow for differential approaches depending on where people are on this ATN framework. Interestingly, though, if you did apply this framework in a clinical context, 47 million adults in the United States would be positive for at least one of the A, T, or N biomarkers. So we also have to think about, we don't want to, frighten and alarm people because there's a lot of older adults who develop amyloid plaques and end up never showing any, signs of dementia. So our brains do change as we age. And so it can be complicated to think about in terms of, when do we want to formally diagnose someone with a medical condition versus when is this more just interesting from a research perspective and wanting to kind of track people over time. So I think there's been a lot of activity and change in terms of the use of the amyloid and tau biomarkers in particular. So we've really seen some amazing breakthroughs in terms of, it was the mid-2000s where we saw amyloid PET scans come on the field. The Pittsburgh group created this PIB compound, where it's amazing. You just inject, a tracer into the bloodstream. It can show up on these images like you see here. In the mid-2010s, we saw the kind of tau PET imaging come on the screen. And then more recently, we're seeing the development of these blood biomarker tests that can detect amyloid and tau. As you might imagine, PET scans can be hugely expensive, several $1,000s worth, very complicated. It'd be fantastic if we could get some of this information from a simple blood test, and we do seem to be on the cusp of that. So I'll talk about amyloid and tau imaging and blood tests a little bit more now, but just to give you a little bit more background on amyloid imaging. So it's typically done with a PET scan, and I mentioned there's a radio tracer that's injected as part of the procedure that binds to amyloid in the brain. So it was back in 2012 that we saw FDA give approval for the use of amyloid imaging, and the approval was for the use of diagnosis in people who already had cognitive impairment. So a typical dilemma for a clinician is, hey, I know this person is cognitively impaired. I'm trying to figure out, is it Alzheimer's that's the cause of their impairment, or is it another type of dementia? So the amyloid imaging might be very helpful in what we call that differential diagnosis. So even though it's been approved for over a decade, it was only back in October that we saw Medicare actually allow for insurance coverage of this type of imaging. And I think part of the challenge there was because Alzheimer's is so commonplace, because these scans are so expensive, I think Medicare was reticent to cover it until they saw more evidence that it was actually going to be clinically useful. But I think, again, I want to underscore, though, that right now, amyloid imaging is not recommended for people who don't have cognitive impairment. But there are, some people out there, kind of like with the ApoE testing, hey, I'd be interested to know whether I have amyloid plaques developing because it could help me plan for the future. But right now, that kind of imaging that use of this imaging is not recommended. Part of the reason why I think Medicare ultimately shifted to be open to covering this was from research like my colleague Gil Rabinovich at UCSF has done in leading projects like this nationwide IDEAS study. So they did this huge project where they enrolled, over 18,000 patients across the country, and they were able to kind of test what's the utility in practice of doing amyloid imaging. And so they hypothesized that use of amyloid PET would be useful to clinicians in differential diagnosis. And they did find that the amyloid PET results did seem to make a difference in terms of changing clinician diagnosis, changing the care plan for patient management. And so it wasn't so huge a difference in terms of major medical outcomes, in terms of like reducing hospitalizations, pretty modest impact, but it did seem to be kind of useful for clinicians at this diagnostic stage. And then fortunately, they also found that disclosure of results did seem to be, did not seem to cause harm or alarm in patients and families. But unfortunately, like with a lot of our Alzheimer's research, it was a relatively homogeneous group in terms of racial and ethnic background. And so I think we see this in a lot of Alzheimer's studies where we need to do a better job as a field at reaching out to minority populations, giving them access to research studies like this. So ultimately, I think hopefully some of that will be, there's a new round of the IDEAS study that's underway right now, actually, where there is a real focus on having a more diverse patient population. And you can see that we do have some sites in Michigan, including in Detroit, that are recruiting for this new IDEAS study. So that's a little bit on amyloid imaging. In terms of tau imaging, again, similar concept to amyloid imaging, using PET technology to try to understand, are tau tangles developing in the brain? Where in the brain are they developing? How dense and diffuse are these tangles? And in 2020, we saw FDA approve tau imaging for clinical use. And so tau for some people is actually more important even than amyloid, even though I think amyloid's got more attention. They're both necessary for an Alzheimer's diagnosis. There should be some evidence of both amyloid and tau in the brain. But it seems that presence of tau tangles is more tightly correlated to people's cognitive functioning than presence of amyloid. So I think even though the therapies that are on the market now are anti-amyloid therapies, I think there's also interest in treatments that will address these tau tangles as well. And of course, tau imaging can be useful not just in the diagnosis of Alzheimer's, but there's other types of dementia like frontotemporal dementia where tau is also important to think about. Now, moving from PET imaging to blood tests, so it was really back in 2020 where we saw kind of these breakthrough blood tests being reported at the major scientific meeting for Alzheimer's is this AAIC, or the Alzheimer's Association International Conference. So in 2020, there was a lot of major findings about blood tests for Alzheimer's disease. Just as a side note, this year's AAIC will be this summer in my hometown of Philadelphia. So I'm very excited for that and hoping that we'll continue to see breakthroughs like this reported there. But blood-based biomarkers, I alluded to earlier, really could be a game changer in terms of just their ease of use. And so there's one blood-based biomarker known as p-tau217 that does seem to be very highly sensitive and specific in detecting Alzheimer's cases. So a thing in science that you look for is you look for kind of the same results across different studies in different countries, different patient samples. And that's what we really have seen with these kinds of biomarkers is whether the studies are being done in Sweden or here in the US, we're seeing, really reliable and accurate blood tests being developed. And so we've seen across different studies suggesting the potential utility of these blood-based biomarkers for identifying people who might be at high risk for future development of the disease. And of course, blood tests are going to be much cheaper and easier to use than neuroimaging. But I think one challenge is, these are in very kind of advanced research teams are doing this. They're very sophisticated. And so I think we need to think about if we, again, scale up. And so we try to move this out into community settings and across a variety of healthcare settings that maybe don't have the expertise and resources of these specialty sites that have done this initial research. You can imagine there might be some issues with broad translation of this kind of technology. But we are already seeing, on the marketplace, some blood tests being marketed. So here's the C2N group has this pre-CIVID Alzheimer's test that has been on the market for a couple of years now, being marketed to healthcare providers to maybe help in a differential diagnosis. And even one company was thinking about a direct-to-consumer blood test to people who don't have cognitive impairment. And so that created a lot of controversy. And so then there's been a lot of kind of pushback against that, a lot of more negative press. So I think this blood test, the marketing for that has really died down because right now I think it really does make the most ethical and clinical sense to really think about these kind of blood tests more in the context of people who already have cognitive impairment and you're trying to figure out what's the underlying cause. But I imagine some of these issues may come up where people might start becoming interested in blood tests just because they have a family history and they don't yet, have any symptoms that they might want to learn this kind of information. So that's a little bit about, the latest blood tests. Again, I think we'll probably hear more in the future. And I think we'll probably see this. I mean, if I had to predict, I would say, one way to think about it is you can imagine maybe in more primary care settings being able to use these initial blood tests as kind of screening tools to decide, does someone need kind of a more advanced workup and maybe a referral to neurology, for example. So sometimes we see this where right now a primary care physician, maybe they do a brief cognitive screening, they do a mini mental status exam and give them, brief, cognitive tests. And if they don't do well, then that's the reason for referral. But you can imagine that maybe the cognitive screens might be used in conjunction with a blood biomarker test to decide, do we need to kind of investigate this more thoroughly and do the more advanced neuro exam and PET scan. So we're not there yet, but it'll be interesting to see if this kind of blood testing becomes part of this model of care of maybe initial screening to inform further diagnostic testing. So I know I've been yammering on for a while here, so let me wrap it up to see what questions you all might have. But I hope I've convinced you that there are several different types of genetic testing that are relevant for Alzheimer's disease. None are recommended as routine standard of care, but they may make sense in particular contexts. I think we talked some about biomarker testing as well, being useful to aid diagnosis of patients with cognitive impairment and track treatment progress. Not yet recommended for asymptomatic at-risk groups, but stay tuned there. I think whether it's genetic or biomarker testing, I tried to point out how these kind of decisions should not be made lightly. They should involve consideration of both the benefits and the risks of testing, thinking about not just the patient, but also the family. And ideally, having a knowledgeable professional available to help guide this kind of treatment decision-making would be important. And I think, again, this is a hot area of research. We're going to continue to have more breakthroughs and developments in this area. So I think you'll probably be hearing more in the future about genetic and biomarker testing, particularly as some of our treatment and prevention options for Alzheimer's improve. So with that, let me stop the slides and I can try to take a look. I don't know, Stephanie, have you been monitoring the chat?
Yeah, we do have one question right now in the Q&A. It says, what age ranges are most interested in getting genetic testing, older or midlife?
Yeah, that's interesting. I think from the studies that we've done, it's actually been more the kind of midlife group that's been more interested. And I think, our take on that is that it seems like a lot of the reasons for, and I'm talking about maybe people in their 50s and 60s, they're often at a stage in life where they're really thinking about things like retirement or advanced planning, or they're thinking about, should I get long-term care insurance or not? Or, what age do I want to retire? And if they have a family history of Alzheimer's, they may be thinking about, well, if I think this is in my future sooner than I anticipated, would it change how I live? And so that's a gross generalization. There's certainly people beyond 50 and 60 who are also interested, but in terms of just the overall percentage of folks who say, yeah, I would really want to learn this information, it often does seem to be kind of this midlife phase where folks are particularly interested.
All right. Any other questions to be addressed?
Yeah, don't be shy. Feel free. I know this is the format. We can't see each other. I guess but you can certainly, if you have anything, put it in the chat or Q&A. Looks like.
All right. Are those with ApoE3 neither at increased or decreased risk for AD?
Correct. They're kind of the average risk group. And again, the most common genotype is the 3-3 genotype. I forget the exact percentages, but it's in one of my slides. And by the way, I'm happy to make these slides available to folks if they're interested. And I think this recording will be posted on our website as well. So yeah, so that E3 is kind of the average risk. The E4 is the elevated risk, and the E2 is the one where it's actually slightly decreases risk. But of course, we have an APOE genotype where we have one allele from each parent. So people could have one E3, but then one E4. Or it's very rare, but some people could have one E2 and one E4. And so then it gets complicated because it's not just based on one allele, but it's based on the combination.
Right. The serum biomarker that was mentioned as being particularly sensitive for AD, p-tau, I think, is it sensitive in the preclinical stages?
Yeah, so I think that's a good question. So it certainly can be useful to do in the preclinical stages. I think there's still research that needs to be done, and for example, in kind of tracking people through longitudinal studies over time to see what would its predictive value be in terms of just how precise it is in predicting who's going to go on to develop Alzheimer's disease or not. So I think the jury's still out a little bit, but I think it's certainly the research is being done where I think you can imagine a future like I was kind of talking about, where people might ultimately want to know this information. And over time, as we learn more, we might be able to use this kind of testing to identify people who maybe need more close monitoring or who might want to use that information to inform their kind of healthcare decisions and behaviors.
Right. Is there any benefit to studying those with ApoE2?
Yeah, certainly. I think there have been some studies that look at, can there be ways in which we can, because the E2 allele does seem to be protective in some respects. So I think there definitely is promise there in kind of trying to figure out, what is the underlying mechanism by which E2 confers protection against Alzheimer's. Like, even though we've known about the links, for example, though, like on the flip side with E4, we've known, like, the first studies came out of Duke in the early 1990s. And we're still learning, like, well, what really is going on? So it takes a long time from, initial finding that's more like just looking at this gene, is associated with this level of risk, to really understanding, well, how does that happen? And I think, I do think there's some promise therefore in kind of closer look at E2, even though E4 has gotten more attention.
All right. Are there correlations between degree of head injury, time of unconscious or not, and susceptibility to AD, and in combination with ApoE4 status?
Yeah, I think there are some suggestions that I've seen some research to suggest that combination of, if you are both A, an E4 carrier, and B, you've had a significant history of head injury, that combination might particularly put you at risk, if not for Alzheimer's disease, but at least for some kind of dementia down the line. And so it's gotten to the point where some experts in the field have kind of thought about, do we want to think about, like, would it even make sense to think about ApoE testing in the context of, people who are, like military combat or even like contact sports, where people are maybe at higher risk for having a head injury. There's even been some discussion, well, could ApoE testing be useful in those contexts to help inform people's decisions? Like, would you even want to go into this sport or into this field, given that combination? On the other hand, I don't think the risk estimates are highly precise there. So I think it's still a relatively early science in terms of looking at that interaction effect, but there definitely has been some work. My colleague, Steve Dukoski, has written a kind of really fascinating commentary in this area a few years back. Looks
All
like we have
right.
another.
Yep. Can long-term care applications ask if you know your ApoE status? Which qualifications are permitted?
Yeah, so I think because Gina does not cover long-term care insurance, as far as I know, and again, I'm not an attorney here, so I might be speaking a little bit beyond my expertise, but my sense is that it's theoretically possible, so because it wouldn't be ruled out by the Gina protections, where it would be illegal, like I said earlier, for a health insurer to ask you your APA status to like say whether they're going to raise your premiums or not. But my sense is that even though it's maybe possible, I haven't heard that it's done much. I think long-term care insurers, there are other ways to find out whether people are at elevated risk for disease that might be less controversial than ApoE testing. So for example, just getting a really thorough family history or even doing like a very brief cognitive screen that might just take a few minutes. My sense is that long-term care insurers might get more value from that kind of risk information than an ApoE test. So that's my sense, is that those kinds of tools might be used more frequently than ApoE testing. But I do think it's important to recognize that the federal protections, do not encompass long-term care insurance.
Right. Is there any risk for AD to those who engaged in head trauma-prone sports such as football but never lost consciousness?
I mean, I think in general, I know head injury is a modest risk factor for Alzheimer's and other types of dementia, but it's a very tricky and complex science there. We have a whole concussion center on campus that really looks in detail at these. And I think what's been interesting, I used to be at Boston University where they study this form of dementia known as CTE that you may have heard about, because a lot of NFL players, on autopsy are found to have this brain disease. And I think it's not just these, dramatic head injuries that are important to think about. I think, in sports like football and even soccer, where you're heading the ball, there's some suggestion that maybe kind of repetitive, like lower level head injury that, don't result in a loss of consciousness or even concussion could still, maybe that accumulation of blows over many years might be harmful. So I think it's really a challenge then, though, to formulate, well, can we give very specific guidance, or so there's no easy answers there, but I do think it's important to think about these issues of head injury and their link to later brain injuries. So I've been kind of encouraged, being a big sports fan myself. I think we've seen a lot of changes both at youth levels, college, pro, and kind of thinking about protections against head injury in the context of sports that maybe lower that risk in a variety of ways.
Hi, thank you for this valuable presentation and answering our questions.
Well, my pleasure. I always enjoy these kinds of talks, and as I said earlier, I wish we could be in person, but I think we're probably all glad on a day like today that we're on Zoom rather than out on the
We'll
snowy
still be able
roads.
to.
But thanks, Stephanie, for this opportunity, and I appreciate the audience participation in the Q&A here, and I'll turn it back to you to wrap up.
Yeah, thank you so much for coming to our event today. If you noticed in the chat, I put the evaluation, so please take the time to fill out the evaluation form. I will also be sending a follow-up email tomorrow with the evaluation. That just gives you a chance to give us some feedback on our events, propose some topics that you want to hear about in the future. So thank you very much for coming today. And I think we'll wrap things up right on time, 1 o'clock.
Yeah, thanks, Stephanie. See you all.
Thank you.